Welcome back to our fourth week of the 6th annual Food Literacy for All. We are so lucky this week to be joined by Dr. Fatima Cody Stanford. I'm going to go through the nuts and bolts in the opening material tonight, and then I'll turn it over to my colleague Winona to introduce Dr. Stanford. And we'll be back at the end, of course, with time for your questions and answers. So just to, let's see, let me advance my screens here. Okay. First, a thank you, as always, to all of our generous sponsors. We couldn't do it without you. We've got the list here, and some special thanks tonight to the Taubman Institute, who helped us out with bringing Dr. Sanford to speak to us. As those of you who've been here before know, but to those of you who are joining us just for tonight, this is a special course that brings together both people from the University of Michigan. I'm Dr. Margot Finn, and I'm joined by Lily Fink-Shapiro from U of M, with community partners represented on our course leadership team by Winona Bynum from the Detroit Food Policy Council. So we're working together to bring this fun academic community partnership together. We've got a lot of students enrolled in the course, and then we have a lot of course, community people and people from around the country and the world who've been joining us in the past week. So it's an exciting year, this new virtual food literacy for all that we're doing. It is free and open to the public. Feel free to share the link, and the recordings are posted after these sessions on usually about a day later, and they're on the SFSI website, which I believe somebody is going to drop in the chat for people to be able to access. There's a couple of ways to engage in with this course. So even though we're virtual, we're trying to make it so that you can ask questions and engage with each other as well as with the speakers. One is through the Miro boards. I believe that link is also going to be in the chat for you, where you can drop interesting quotes, you can ask questions, you can upvote each other's comments, a way to share and highlight some of the most interesting things that you're hearing during the presentations. There's of course poll questions, and those of you who are taking the class for credit know that you need to answer a majority of the poll questions to get credit for having been here tonight. And you can also tweet at Food Literacy for All, hashtag Food Literacy for All, to engage with other people on Twitter. And if we see those questions, we'll try and incorporate them as well. But the best place to drop questions for the speaker is in the Q&A box. So please do use that to ask questions for Dr. Stanford. We'll try to get to a number of them at the end of the presentation tonight. And one special bulletin for anybody tuning in, and this is true for students, but also especially for our community members, anybody who's joining us tonight. If you have any experience or expertise in the food system and would be willing to talk to somebody in this class, a student in the class, for about 15 minutes, an informational interview about your expertise and experience, we now have, we've got a database where we're collecting willing experts and food systems practitioners. So I, again, believe somebody's going to drop that link in the chat. Only if you're willing. We're going to make it so that students can see if you've been contacted. So you should only be contacted by one student. That is our commitment to you. But if you have 15 minutes to help our students know a little bit more about the community members who are joining in and get a more holistic view of the food system. Obviously, we only have 14 weeks, so there's only so much that we can do. But the food system is vast, as we are all learning every week. So again, with thanks to those of you who are willing. And I have a poll question to just see a little bit about who's tuning in today and from where. So if you have a chance to let us know whether you are a current student enrolled in the class, not somebody who's enrolled, but somebody who's been here before. If this is your very first time joining us, we would welcome also, and we'd love to hear about that. And you can answer multiples of these. So many of these may be true for some of you. Are you new to thinking about weight bias, our topic for tonight? Or have you already done a lot of thinking about weight bias? Is this something that you're coming to us with some experience in? So we'll let that be open for a minute, gather some answers.
A lot of 75% of you are students enrolled in the class. 16% of you are enrolled and are not enrolled, but you've been to at least one food literacy class. 8% of you welcome. This is your first time ever attending, about 20 folks. And 31 people say they're new to thinking about weight bias. And then another 49 people have done a lot of thinking about weight bias. So welcome to all of you and where you're at.
Excellent. Thank you guys so much. I'm going to hand it over to Winona to introduce our speaker for tonight. And sorry for the tech difficulties here, folks.
Thank you, Margot. It is my great pleasure to introduce Dr. Fatima Cody Stanford. Dr. Stanford is an associate professor of medicine and pediatrics who practices and teaches at Massachusetts General Hospital. Harvard Medical School as one of the first fellowship-trained obesity medicine physicians in the world. Dr. Sanford received her BS and MPH from Emory University as an MLK scholar, her MD from the Medical College of Georgia School of Medicine as a Stoney Scholar, her MPA from the Harvard Kennedy School of Government as a Zuckerman Fellow in the Harvard Center for Public Leadership, and her Executive MBA as a merit-based scholarship recipient from the Quantic School of Business and Technology. She completed her Obesity Medicine and Nutrition Fellowship at MGH HMS after completing her Internal Medicine and Pediatrics residency at the University of South Carolina. She has received numerous awards. She has served as a Health Communication Fellow for the Center of Disease Control and Prevention, as a behavioral science intern at the American Cancer Society. Upon completion of her MPH, she also received the Gold Congressional Award, the highest honor that Congress bestows upon America's youth. And like I said, I could go on and on. Dr. Sanford has just received so many awards. I would probably make her uncomfortable naming them all. And this is just her short bio, but so happy to have her here today. She will explore the harmful impacts of weight bias on the impact on the health outcomes of the population. She will ascertain how health professionals harbor implicit and explicit bias. She will evaluate strategies that medical organizations have taken to fight weight bias. Dr. Sanford, we cannot wait to hear you. Welcome and thank you.
Well, thank you so much, Winona. I want to thank Dr. Finn. I want to thank Lily and the whole team for having me here today, all the way from Boston, where we just got 23.6 inches of snow. So we beat you guys in Michigan, which I know we like to compete. I'm going to go over my slides and share my screen here just for a moment. We will go over a lot, and a lot of what I will teach you today will seem new, particularly as we talk about obesity as a disease, which is different from how we're thinking about it. So today I will talk about the role of weight and race bias in health outcomes. And again, thank you so much for the warm introduction. I seem to like school. I thought I was only going to have 4 degrees, now I have 5, and who knows, 6 may come. But I am not actively pursuing that at this time. It's a delight to be here from Boston, Massachusetts, into Michigan. These are the objectives for today. So they include the following. We're to discern how weight bias and stigma actually contribute to energy storage. So by energy storage, I mean accumulation of adipose, or what we call fat. Adipose is an organ, fat is an organ. I do not utilize it in any other way. To learn about how early life influences actually really play a large role in weight bias. We'll determine the deleterious impact of weight bias on health outcomes. And we'll ascertain how health professionals actually harbor both implicit, which is that bias that we don't know that we have, and then that explicit bias, the bias we do know that we have. And then we'll evaluate how organized medicine organizations have really sought to dismantle weight bias. So we're going to start with a poll, and I think I turn this over to the team to go through these questions. These questions we'll have you ask at the beginning, and then we'll see how you do based upon what I teach you during the course of today's talk. So this first question is, what is the average age in which children begin to demonstrate signs of weight bias? Is it A, 12 months of age, B, 20 months of age, C, 32 months of age, and or D, 48 months of age? So all of these numbers are quite low, and this is intentional, but at what age do children really begin to demonstrate signs of weight bias? If you can answer that in the poll now, that'd be great. All right, so looking at this, there's a smattering of people. So I would say that obviously the winner would be 32 months of age, but only 40%. That's not a very convincing majority, followed by those that are 20 months. And then there's a tie between 12 months and 48 months. All right, let's move on to our next polling question. I'm going to move the slide and we can move on to the next polling question, which is weight stigma has not, I know this is not how we like to word questions, but let's go with it, been associated with which of the following? Is it A, disordered eating, B, metabolic syndrome, C, elevated blood pressure, D, high triglycerides, which is a type of cholesterol, or E, low HDL, another type of cholesterol, what we call high density lipoprotein. What has weight bias not been associated? So there's one thing on this list that it's not been associated with. All right, so I would say that we do have a more of a clear answer here. More of you believe that this has not been associated with low HDL, that low HDL, high density lipoprotein, the good cholesterol. So you guys don't think it's been necessarily associated with a low level of good cholesterol. That's followed by metabolic syndrome, then high triglycerides, elevated blood pressure, and then disordered eating. Okay. Great. I like this engagement and involvement. Let's go to the very last question before we really dig deep. Which country do you believe has the highest level of weight bias? Is it Australia, Canada, Iceland, United States, or there's similar levels of weight bias in each of the countries that are noted here? All right. So it looks like we believe the United States to have a high level of weight bias. And that's followed by, there's similar levels of bias between each of the countries. You guys did not believe that the Aussies, the Canadians, the Iceland's individuals, I don't know how you say Icelandic maybe, individuals had high levels of weight bias. So let's look at this as we get going. And thanks so much for participating in the poll. We'll cover these things. So let's start with this concept of BMI, which is not one of my favorite topics of discussion, but I have to embrace it because it's important for me to recognize that BMI has set us up for some issues and failures as we think about weight and weight status. However, we do know that the current data or current structure of how we evaluate weight, whether flawed or not, is BMI, which is body mass index. It takes into account height and weight to determine what one's weight status is. Now, the problem with BMI, there are a couple of problems. Number one is it does not give a direct measure of adiposity. When you hear me say adipose, I'm talking about fat tissue. So when I just calculate someone's height and weight, I don't know how much is muscle, much versus water versus fat, for example. In addition, when we get to the BMI table, which I will go over on the next chart or slide, it's important to recognize that BMI is not derived from medicine. So the BMI tables were based upon the Metropolitan Life Insurance Company data back from the 1930s and 40s. So this comes from actuarial data, not from medicine. So BMI cutoffs were utilized to determine the insurability for life insurance for white individuals here in the United States. They basically determined that if you had certain weight status, you were at higher risk for dying than if you were at lower weight status based upon the white individuals that they were insuring during those times. So let's look at how this is defined currently, and you can see what people will use. Now, I can tell you I do not use target BMIs for any of my patients. I'm just going over and giving you the data as it lies. A person is considered to have underweight if their BMI or body mass index is less than 18.5. A person is considered to have normal weight status if their BMI is between 18.5 and 24.9. Then we get into those that have overweight. Notice I didn't call them overweight persons. We want to use people first language. Patients have overweight and obesity. They are not characterized by it. So a person has overweight, their BMI is 25 to 29.9. And then we get into our three classes of obesity: class 1, class 2, and class 3 obesity, what we consider to be mild, moderate, and severe, or mild obesity being classified as a BMI of 30 to 34.9, moderate obesity being classified as a person with a BMI of 35 to 39.9, and then those with severe obesity, a BMI greater than or equal to 40. Now, I want to point out also here that we have redrawn the BMI charts for Asian adults. For example, these cutoffs actually do go below this. I redrew them for all adults in 2019 and published on the Mayo Clinic proceedings. And interestingly enough, the group that has the highest rate of obesity, Black women, the cutoffs actually do change for that population alone. I do want to take us through looking at the prevalence of obesity based upon something called the BRFSS that you see at the top of your slide here. BRFSS stands for Behavioral Risk Factor Surveillance System. The reason why I'm spending some time talking about that is that this is self-report data. And the reason why that's important is because we tend not to be very honest when we're reporting our weight, particularly. We tend to underreport our weight. So while I will show you these heat maps, which will show you the prevalence of obesity based upon the BMI criteria we just talked about, recognize that there's likely underreporting of what we'll see in the next few slides. So let's point out what we're seeing on the left side of, or on the right side, I'm sorry, at the bottom of the slide. We have this prevalence of obesity based upon, I guess, percentages. So as you can see here, when we're looking at all adults in states and territories here in the US in 2015, there's no state that has a prevalence of less than 20%. Green is between 20 to 25%, okay, prevalence. Notice the darker the color, the kind of stronger the heat on the map, the darker the color we get into. So our yellow is between 25 and less than 30%, orange between 30 and less than 35%, and then crimson, which for Harvard usually is a good thing, not so great when we're talking about this map. This is higher rates of obesity. So if you're looking at 2015, which wasn't long ago, we're just seeing West Virginia, Alabama, Mississippi, and Louisiana with this higher prevalence of obesity based upon self-report data. But I want you to store this in your memory because we're going to go through a few additional maps pretty quickly, okay? This is amongst all adults. So I just want you to remember, so this was 2015, and look at the jump. Oops, we're going backwards now. Look at the jump that we happened once we got into 2018 to 2020. So we see that there are definitely significantly more states with more oranging and crimsoning of the map. We have several additional states that have now been added. Look for Michigan. Michigan was not in that higher rate of obesity in the previous slide, but is now there. I wanted to point that out because I know that is who I'm primarily speaking to today. And so we've seen that climb during the course of this pandemic. This is the most recent data available from the CDC today. Now, I do want to break this out by racial and ethnic group. And the reason I'm doing this is to show you that there are disparities that exist as we talk about this disease that is obesity. Let's look at non-Hispanic white adults starting in 2013 to 2015. You can see here that we have Colorado, DC, and Hawaii that do have this prevalence of obesity of less than 20%. You can come and, of course, look for Michigan up here, this Massachusetts here, my home state of Georgia down here. But you can see here in this non-Hispanic white adults, we're talking about West Virginia and Puerto Rico with those higher prevalence of self-reported obesity rates. Let's look at the jump that happens when we go to non-Hispanic white adults in 2019, and then finally in 2018 to 2020. And we can see that shift where we do see a higher prevalence of obesity, oranging and crimsoning of the map, particularly here in the East and in the Midwest. Let's look at what happens when we look at this and break this out by looking at Hispanic adults. This is the map from 2013 to 2015. We can see very little green on the map. DC, you can see there with that speckled green, and then we have Vermont and Kentucky with kind of that lighter green color, but kind of a lot of crimsoning and oranging of the map. Now, as we go and make our way up, you can see that we start to introduce a new color. And I want to point out Michigan. So I'm thankful that you guys have me here. For Hispanic adults, Michigan and Indiana shifted into this new color, beyond crimson into this wine color, with prevalence of obesity greater than or equal to 40%, seen for the first time in 2020 amongst Hispanic adults. Now, as a Black woman physician scientist, none of those maps actually brought me to this work. It was indeed this map that brought me to this work. This is the self-reported obesity rates among non-Hispanic Black adults here in the United States. This is taken from the 2013 to 2015 data, and I think we can all agree that this is largely a crimson map, including my both birth and home state. But what you can see here is that this is different. Now, what do you anticipate as we make that, I guess, pass over to 2020 is you expect indeed this, that we see significant wine color throughout the states here. You can see Michigan up there at the top. And so we can see that there is a disproportionate impact of obesity on communities of color. Now let's flash over to Asian adults. I'm not a huge fan of this map for many different reasons. First of all, there are very specific Asian cutoffs for BMI that have been standardized and in place since 2003, 2004. When the CDC put out this map, they did not utilize that. And so this makes it appear that there's no issue really amongst Asian adults as it relates to with obesity, with an exception of Alaska maybe. But we know that not to be true based upon the BMI cutoffs, which do differ for Asian adults and things of that sort. So let me teach you about obesity. You can't have an obesity medicine physician scientist come to you and talk about this disease without me teaching you about the disease. And so this is where I really want to spend some of my time as we talk about this and how the lack of knowledge of this really leads us to this idea of weight bias. So first of all, when we talk about energy balance, people think that weight is super easy to understand. It's all about your calories in, right? The amount of food and beverages that you eat, and calories out, meaning your bodily functions and your physical activity. And if you can just get this correct, we should all be exactly the size we want to be, right? If you believe that to be true, you are indeed wrong. It is so much more complex than this, but this is the mantra that we continue to perpetuate both in medicine and in the lay population for those of you who are not directly involved in healthcare. This is problematic because this is what we tell you. We tell you to go look at your calories, eat less calories, exercise more, and if you just do those things, you should be fine. But we know that this is indeed incorrect. So I'm going to teach you about how this actually works. What we need to know is that obesity is a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having this disease. And I want to go to the most important organ as we relate to looking at one's weight status, and that is indeed the brain. The brain, particularly if we were to slice the brain, we would get to this portion of the brain called the hypothalamus. The hypothalamus is getting signals from our fat tissue, what we call adipose tissue. It's getting signals from our small intestine, our large intestine, our pancreas, and our stomach is sending signals back to the brain to tell us not only how much to eat, but how much to store. So nothing about willpower, nothing about me accepting my body as it is. Literally, this is how your brain has decided it wants to do its work. So let's talk about the brain. The brain is getting signals from our diet. I never ask my patients how many calories they're eating. That is not as important as the quality of what they're eating. And by quality, I'm talking about lean proteins, whole grains, fruits, and vegetables being the predominant source of what they're taking in. But just because your diet looks like what you see on my screen right now does not mean you won't have obesity or even severe obesity. And that is a bias that we typically have towards those that have this disease, that we assume they're eating incorrectly. Now, physical activity is indeed extremely important as we talk about weight and weight status, but we as doctors and the healthcare profession and even the lay population sell this all wrong. We tell people to go and exercise to lose weight. And when people exercise and they don't lose weight, you can imagine they stop exercising because they believe exercise is supposed to lead to weight loss. On average, for most individuals, nothing is ever 100%, but for most individuals, when you exercise, it causes weight stability. Across our adult lives, we tend to gain weight incrementally, maybe 3 pounds this year, 5 pounds the next year, 6 pounds the next year. You can imagine that adds up over time. Our exercise helps us keep us stable, even if we're at a higher weight status than we might like. Now, sleep quality plays a large role in how the body regulates weight. A key component of this issue is the brain regulates sleep. The brain, if it's not getting proper sleep, you can imagine it's going to dysregulate those pathways that we just talked about. Medications that we as doctors prescribe contribute to 20% of obesity in the United States alone. There was a great paper that just came out of the NIH and the CDC combined, which demonstrates this. Medications like lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Ambien, Trazodone, Lunesta, gabapentin, glyburide, glipizide, glimepiride, metoprolol, atenolol, propranolol, long-term insulin, long-term prednisone, just to name a few. All of these are types of medication that can contribute to significant weight gain without any changes in behaviors as it relates to diet, physical activity, for example. Now, this is another sleeping person, and this is intentional for me to put another sleeping person. This was not an error. What you can see here is that this person is sleeping during the daytime. This is disrupting his circadian rhythm. Circadian rhythm disruptions, meaning that we are awake in the nighttime instead of being asleep and sleeping during the daytime. This disrupts those pathways that regulate weight and weight regulation, such that night shift workers tend to have much higher weights, not because they're eating or doing bad things, but just they're deviating from the natural course of what their body wants, which is to be awake when it's bright outside and asleep when it's dark outside. And then finally, thermogenesis, which is just how much the body burns at rest and with activity. A lot of that's genetically determined. It's kind of the card you were dealt. This is not something that we typically can significantly change. All of these definitely play a role in how the body regulates weight. And now we get to one of my absolute favorite slides, because this shows you why that calories in, calories out model that's been perpetuated for so long is indeed wrong. This is all of the potential contributors to obesity that we know of as of today. What I want you to see is on the left side of the screen, these are things that are inside of a person that can lead to weight gain, so things in the gray. These are things that are outside of a person that can lead to obesity, so this whole right side. These things here in this top row, these things increase what someone takes in. And here at the bottom, these things decrease how much someone's able to burn. And then finally, here we have things that affect either how much we're eating or how much we're burning, or you can see this word here, unknown. We haven't yet figured it out. Now, you can see there's a lot of stuff on the slide. There's no way for me to go over all of this, or we would not have any time left. But I wanted you to see the complexity of it being way beyond calories in and calories out. Now, let's look at some of those big categories, those big colors we saw in that previous slide. These are the big categories of contributors or influencers to obesity. The big categories include biological or medical reasons, why someone may struggle with their weight, food and beverage behavior and environment, maternal and developmental, social, psychological, economic, and then environmental pressures on physical activity. All of these play a role. We're going to pull out a few key ones so that we can get a sense of like what was in that slide that had all of those things on it. Contributors to obesity inside of a person that may increase someone's intake are things like hyperreactivity to environmental food cues. Maybe you walk past that pizza place and immediately you notice it, and I walk past, I don't even notice there was a pizza place there. That is something that we pay attention to. Delayed satiety, which means it takes you a long time to feel full. That a lot of times is just derived with things that are going on inside of you. Disordered eating, like things like binge eating or anorexia, bulimia, for example, those things can potentially lead to intake even in the anorexia side. What we see is those that have anorexia typically, unfortunately, develop obesity as they've been trying to overcome those pathways of the brain, and the brain ends up defending a higher set point for weight. Now, things that may decrease how much you're able to burn are things like the gut microbiota. And you're like, Dr. Stanford, what does that even mean? That means that the bacteria in the gut of those that are lean differ from those that actually have obesity. So much so that we at Mass General and other places throughout the country are doing experiments where we're taking the gut microbiota out of lean individuals, placing it in those that have obesity, and seeing weight loss with no changes, just repopulating their gut with basically more favorable bacteria in the gut. Thermogenesis, we talked about, that's how the body burns. And then obviously, if someone has physical disabilities, you can expect them not to be able to burn in the same way as someone who's able-bodied. Now, things that increase intake and decrease expenditure are things like genetic and epigenetic factors. And one key thing that people don't recognize is that weight is more heritable than height. So I'm going to say that again, because that's a little bit confusing when I say that the first time. Weight is more heritable than height, which means if you have parents that have obesity, there is a 50 to 85% likelihood that you yourself will have obesity, even with optimal behaviors like diet, physical activity, sleep, stress maintenance, etc. Age-related changes are particularly important in women's lives. So there are three main times in women's lives where hormonal shifts cause major weight change. For the first time is when they get their menstrual cycle, which we call menarche in adolescence. If someone gets pregnant, whether or not they carry that to term, that shift in getting pregnant can cause major weight shifts. And then at the time of menopause, that's where we see women going from having a gynoid distribution of fat, which is fat concentrated in the hip, buttock, and thigh region, female-like pattern of fat, to having an android, not the phone android. Android means male-like pattern of fat, which is fat stored in the midsection, or what we call central adiposity. Mood disturbances like depression and anxiety also are things that can contribute to weight maintenance. Now, when we talk about things that are outside of an individual, we're talking about things that were inside in the previous slide. Things that increase intake are things like environmental and chemical toxins, pervasive food advertising or large portion sizes. Things that may decrease the ability to burn are things like your built environment. If it's not set up for you to be active and move, you can imagine that'll affect your expenditure. Sedentary time, so I'm sitting here talking to you guys instead of doing a workout, obviously that'll decrease my expenditure. And labor saving devices like using like a dishwasher, for example. Things that increase intake and decrease expenditure are things like weight bias and stigma, which we'll make a transition to in just a moment. Believe it or not, this actually can contribute to those issues. Weight cycling, which means that you jump on this fad diet and that fad diet and then do this exercise program, but don't ever sustain any of those things. That weight cycling actually defends a higher set point for weight and leads to obesity. And then we talked a little bit earlier about maternal and paternal obesity. Now I'm going to shift and make myself a bit vulnerable. I'm going to introduce you to me in the early 80s. This is me here in my dance class at Spelman College in Atlanta, Georgia, which was where I was born and raised. This is my sister. My sister's one of my favorite humans, so she somehow gets profiled also. Now, this is not just to show you a cute picture. This is to take you to a story that has caused me significant pain because it's caused a friend of mine significant pain. I was at an obesity conference, at least I'll say about 4 years ago or so, 4 or 5 years ago. I'm not quite sure exactly when. And a woman who I've known since this time actually took dance with me at Spelman College, comes up to me. She keeps trying to pull me aside, and I'm hard to pull aside because I like to talk. So it takes her about 30 minutes. But after 30 minutes, she's successful in pulling me kind of aside and in the corner. And she says the following to me. She says, Fatima, I don't know if you recognized it, but I've always been standoffish towards you. Now, I've known her since I was 5. I'm in my 40s, so you can get a sense of about how long this has been going on. And she says, well, there's a reason why I've been standoffish towards you. When we were about 5 or 6 in dance class, you came up to me in class and told me that I was fat and you walked away. And I've been waiting for 35 plus years to tell you how harmful that was and how that's hurt me. So I know that you guys have had a conversation about embracing the word fat. Let me tell you, when people hear that they're fat on any playground at any age, at any young age, they do not embrace it as a compliment. So she tells me the following. She says, I've seen you doing this work, talking about weight bias and stigma. And I feel like if you are capable of doing this work, anyone is capable of change. So in this story, I'm the villain. At 5 years of age, somehow I said this to her. I don't remember saying it. Doesn't matter. She remembers it. And I do remember visually seeing her that way. But she had waited for 35 plus years to have the courage to come up to me and tell me, how this affected her life. So this is what we have to think about when we're thinking about the utilization of words that are harmful and actually not reflected in the science. Let's talk about bias in Western societies. There are the 2 most common forms of bias in the United States, which include race bias, followed closely by weight bias. Let's talk about race bias first. If you were to perform a Google search in 2016 for young Black boys on Google, the search algorithm back then would only return mugshots of young Black boys. If you did the same search for young white teens, you returned with smiling faces in groups or holding a soccer, football, or basketball. When this story aired in the Washington Post in 2016, Google did change its search algorithm. So if you were to do that same search today, I haven't done it actually today, but after this time, you should not be immediately returned with mugshots of young Black boys. If you look to the right side of my screen here, we can see that we have bias about race, but we also have bias regarding weight and weight status. If someone's lean, here are some of the adjectives we might use to describe them. They're vain, superficial, conceited, ambitious, mean, okay? Whereas if someone has obesity, we have additional labels that we might utilize. Someone's lazy, insecure, undisciplined, passive, or even nice. But these biases set us up for poor interactions regarding these issues within individuals. So let's come to a key question here. At what age do we really begin to exhibit weight bias? This was a study that was published in 2016 in the Journal of Experimental Child Psychology, and they looked at mom and children. So a mom and child diet, so 70 pairs of mother and child. And what they found was that the older infants around 11 months actually had a bias for looking at figures that had obesity. Now, by the time they got to 32 months of age, they actually prefer to look at lean individuals. And this bias was based upon their mother's anti-fat bias or anti-fat attitudes. And so often when I give this talk, particularly if I'm listening to parents, they're like, well, I don't see anything bad about individuals that have obesity, but it's also what you're not saying. Let's say you're watching a television show or you're on social media and you always comment positively on the lean individual and you never say anything negative about those persons that have obesity. You just don't say anything at all. That message or signaling that's being sent is that they are not as valuable as those that are lean. So that is something that people aren't aware, if they're not explicitly stating that they can be doing. Now, I didn't want to just focus on the moms. I realized that there are other individuals involved in raising children. This particular study also came out in 2016 in the British Journal of Developmental Psychology. And this was exploring the role of parents in transmitting body type stigmas. And in this particular thing, they looked at a larger subsample of 279 3-year-old children and their parents, right? So both parents, if they had 2-parent households. The parents completed this self-report body size attitude, and the children were interviewed, right? Because they couldn't quite complete that at 3 years unless they're a savant. What they found was that over time, negative attitudes towards large bodies and awareness of weight loss strategies ensued, but this was solely based upon the parents and their beliefs. So the parents have huge implications. Notice this is at 3. In the previous slide, we're talking about 32 months of age. So you might wonder, what does this even mean? These people just need to really just get thicker skin? And I'm going to say the answer is a resounding no. This is a study that came out in 2017 in Preventive Medicine, and it looked at weight teasing in adolescence and weight-related outcomes in adulthood. And so this study sought to identify whether this weight-based teasing in adolescence actually predicted adverse eating and weight-related outcomes 15 years later. They looked at over 1,800 individuals that they studied from 1999 all the way to 2015. And they wanted to determine, was the source of teasing also, did it have an impact? So if it was coming from your peers versus your family, did it play a role? And I want to show you this. This is what what it showed was that weight-based teasing in adolescence actually predicted a higher body mass index and obesity 15 years later. Females appear to be affected by both peer and family-based teasing, whereas males tended to be only affected by their peers, so what their peers say. So what this led to was binge eating, which then led to dieting, which then led to unhealthy weight control, body image issues, and issues with higher BMI. And so this whole thing is a vicious cycle. So let's talk about weight bias internalization. And when we talk about weight bias internalization, we're talking about if you experience weight bias, do you internalize that harmful behavior? So what they did in this particular study that published in the Journal of Obesity is they looked at blood pressure, waist circumference, fasting glucose, triglycerides, and HDL in 178 adults with obesity during a weight loss trial. In this, they got to, 159 actually completed, and you can see this was predominantly female, a higher percentage of Black individuals, and the mean BMI was in that category of having severe obesity, meaning a BMI greater than or equal to 40. 51 adults of this 159, which is about 32.1%, actually had the criteria of metabolic syndrome. And what they found was that height weight bias internalization actually predicted a greater odds of metabolic syndrome and high triglycerides. I think we may have seen a question related to that. And what we do know is that the mental health of persons with obesity who experience bias is really bad. This bias leads to physiologic stress that goes on inside of the body, which then subsequently leads to weight gain. So when we experience stress, what happens typically is that our body stores more adipose or fat tissue. That leads to weight gain, which then leads to disordered eating, which then leads to maladaptive behaviors. Let's look at what happens when we look at medical students. So this is a study called the Changes Study that happened in medical schools, enrolled at medical schools around the country. You can see there's 49 medical schools here, both private and public schools throughout the United States. And they looked at 1,795, about 1,800 individuals at the beginning of their first year of med school and at the end of their 4th year. So they monitored them over a course of time. And they did some web-based surveys looking at weight bias and medical school experiences and things of that sort. So I'm going to show you, and let's talk about implicit bias. So they compared these medical students against the public. So the Changes group is the medical student group we just talked about, and the public is the other group. So this took place from 2010 to 2014, and what you can see is that implicit bias did seem to increase within the public, while it decreased within the medical student cohort. So that means that that bias that they have internally held that they don't know they had, it decreased. So that's great. But I can't make medical students seem really great, because unfortunately, what we actually saw subsequently was that there were changes in explicit bias. That's that bias we know that we have. So you can see here in the general public, it would say that things stayed around the same. And while medical students did start off lower, there was an increase in explicit bias towards those that have obesity over the course of their medical school career. So what are persons that they are being exposed to teaching them? What is it about that environment that makes them feel empowered to have this explicit bias? I think that's unfortunate and obviously poor. So what they decided was that medical schools may reduce medical students' weight biases by increasing positive contact between students and patients with obesity, and eliminating unprofessional role modeling by faculty members and residents, and altering curricula on treating difficult patients. Now, I put this word here because I didn't like how they were trying to reduce bias, but then they said difficult patients, right? Assuming that patients that have obesity are difficult, which I do not agree to be true, but this is taken directly from their study. Now, this slide is extremely important, and is one I do want to spend a little bit of time on, because it talks about this idea of weight stigma and how it leads to stress. When this leads to stress, this affects eating and physical activity behaviors, where we see binge eating, increased caloric consumption, maladaptive weight control, disordered eating, lower motivation for exercise, and then less physical activity. This actually leads to physiologic reactivity, where we see increased levels of cortisol, which is a stress hormone, C-reactive protein, another stress hormone, increased hemoglobin A1C, which is your average blood sugar over the course of 3 months, and elevated blood pressure. Weight stigma actually affects how people interact with healthcare services. There's poor treatment adherence, less trust of us as healthcare providers. There's avoidance of follow-up care. There's a delay in preventive health screenings like mammograms, and colon cancer screenings like colonoscopies, poor communication, okay? All of this leads to weight gain, which actually causes psychological health and distress, where we see depression, anxiety, low self-esteem, poor body image, substance abuse, and unfortunately, suicidality. This leads to physiologic health and distress, where we see poor glycemic control, which is poor blood sugar control, less effective chronic disease self-management, more advanced and poorly controlled chronic disease, and then lower health-related quality of life. So this weight stigma leads to poor health outcomes. Now, I told you I wanted to come and look at what do we see around the world. You guys felt like the United States must have the highest rates of weight bias, because we do tend to be kind of cruel. So this particular study that was published in the International Journal of Obesity looked to the extent of weight bias, and was it consistent across countries? They looked at attributions of behavioral causes of obesity and beliefs that obesity is attributable to lack of willpower, which I did not mention, and personal responsibility, which I also did not mention. If that was there, that suggested stronger bias. And they looked at the magnitude of weight bias that was stronger among men. Magnitude of weight bias was stronger among men and among other individuals. So what they found was that it was consistent across countries. So there were a few of you guys that got that right initially. The United States, while bad, was just as bad as Australia, Canada, and Iceland in this particular evaluation. In terms of anti-discrimination laws against individuals with obesity, this was looking at a study that published in Obesity Facts in 2017, and it was looking at the German, US, and Iceland stance on obesity anti-discrimination laws. And what you can see here is that there are some differences in what people think in terms of percentages. You can see that in the US, there are more people that support the inclusion of body weights in civil rights law, which is interesting, which kind of goes against what we would think. That legal protections of people with obesity, should there be there, like those with physical disabilities, kind of similar in Germany and the US, but really low in Iceland, for example. And the list goes on. We won't go through all of those questions, but you can see that there are some differences between countries. And the US, while we are bad, doesn't fare out so horribly there. So let's, I'm just going to revisit the questions. Hopefully you guys learned this. What's the average age in which children began to just demonstrate signs of weight bias? It's 32 months of age, very early in life that we really begin to see this as an issue. Question 2, weight stigma has not been associated with which of the following: low HDL, which you guys, I think, got right, if I can recall the responses at the beginning. But the last one you guys did get wrong. Which country has the highest level of weight bias? There are similar levels of weight bias in each of the countries listed here: Australia, Canada, Iceland, and the United States. Now, I talked about organized medicine and what we have done to try to, get rid of or eliminate or help reduce. I think help reduce is probably most appropriate. Weight bias here at the Massachusetts Medical Society, one of the oldest medical societies in the country. I helped actually author this bill in 2016 called Preventing Weight Stigma and Discrimination Towards Persons with Obesity. That passed our House. It says the Massachusetts Medical Society recognizes that weight stigma in healthcare setting leads to disparity of care and poor health outcomes in patients with obesity. HP means health policy, okay, if you see that. The Massachusetts Medical Society will develop and promote educational information to physicians and physicians in training about weight stigma. D is a directive, okay? And the last directive, that the Mass Medical Society will advocate for legislative policies and institutions and practices to prevent weight stigma. So this in 2016 passed and subsequently led to the passage of the American Medical Association, which represents 270,000 physicians in the United States. And this is what passed the House in 2017 at the AMA. Just think of the House as kind of like Congress for doctors. Our AMA encourages the use of people first language, patients with obesity, patients affected by obesity, in all discussions, resolutions, and reports regarding obesity. We encourage the use of preferred terms in discussions, resolutions, and reports regarding patients affected by obesity, which include weight and unhealthy weight, and discourage the use of stigmatizing terms, including obese, morbidly obese, and fat, and will educate healthcare providers on the importance of person-first language in treating patients with obesity, equipping their healthcare facilities with proper sized furniture, medical equipment, and gowns for patients with obesity, and having patients weighed respectfully. As you can see, these are terms that I do not utilize. We talked about the harmful use of the word fat, even though people have reclaimed this. It is never seen positively on the playground or in dance class. I don't use morbid to explain any other disease process, including COVID-19, which has killed almost 900,000 individuals here in the United States. So why are we going to call it morbid obesity? So you can see where the stigma even lies in the terminology. So in summary, weight stigma has a negative health impact. And that negative health impact is both on the physiological health and psychological health of those that have the disease of obesity. It's seen, however, this white bias as early as infancy. Maternal and paternal anti-fat bias actually influences children and has huge implications for interactions that individuals have. Weight bias may be mitigated by proper training in health professionals. So we learned from that changes study that we can potentially teach medical students to be better humans. I do want to give you this reference. This is a book that I wrote here out of Mass General. You'll see in the bottom right corner, our Psychiatry Academy with my psychiatry colleagues here at the Mass General Hospital. It's called Facing Overweight and Obesity, a complete guide for children and adults. And it explores the vast, both medical, media and its influence on obesity, et cetera, bias. And I really think it's a helpful tool. It is available on Amazon.com. I do want to thank you so much for your time. My name is Dr. Fatima Cody Stanford. You can feel free to follow me on social media on either LinkedIn, Twitter, or Instagram at Ask Dr. Fatima. It has been a delight being here with you tonight, and I look forward to entertaining questions.
Thank you so much, Dr. Stanford. Great presentation. And I have a few questions for you, and I know that the Q&A box has also been filling up with questions. So I first just want to start with a question. So I come from a public health background. So, in public health, obviously we're all about prevention. And I see you use the term obesity treatment, which is, to me curious. I want to hear more about. And one thing when I think about Western medicine, we associate that this is evidence-based, right? We're doing medicine because it works. And so my question to you is, you probably know the percentage, I don't know what it is, but I know it's very low, that when people who have obesity, who are trying to lose weight, we know that it very rarely works. Maybe you can fill in
I can give you those numbers. I can't wait to tell you that part. Yes.
Good. So I want to hear about that and how you reconcile, this evidence-based medicine with how do you do something that we know almost never works? And there's so many.
I think the problem is that we've been using the wrong strategies. When we treat other chronic diseases, we don't just use lifestyle, right? Like that's just not what works. But that's what we do with obesity. We tell people eat less, exercise more. About 5% of the time that leads to major changes, right? And so literally 95% of the time it fails. The problem is that we don't utilize those other evidence-based therapies. So as a physician science, I study those other things, i.e. medications, surgery, devices, et cetera, that we utilize for patients that have obesity. Just earlier today, I did an interview where we talked about, well, gosh, Dr. Stanford, can we talk about your patients and how they gained weight during the pandemic? 90% of my patients lost weight during the pandemic. And that's because I was using those evidence-based tools, i.e. medication, surgery, et cetera, with them to help treat their brain. My medications act on the brain to change how the brain sees weight. Bariatric surgery acts on the brain to change how the brain sees weight. So I'm using the evidence, the science, putting it together. And so my patients, I guess the question I was also asked, I think in an interview last week, well, how many of your patients are successful? I would say somewhere between 95 to 97%, which is super high, right?
Wow.
It's only because I know the science and I utilize the science to help my patients achieve the happiest, healthiest weight for them. Now let's look at the utilization of bariatric surgery and medications, just to use those two in the United States. Approximately 1.5% of people that meet criteria for metabolic and bariatric surgery get surgery in the United States as of today. And I published a paper that looked at medication use, published in the Mayo Clinic Proceedings about maybe 2 months ago. And only about 1% of patients that meet criteria for medications get access to those. Now, let's think about diabetes. We're going to throw in another disease process that people may have heard of. I think you guys may have heard of diabetes. I can promise you that if I were in Michigan or Massachusetts or my home state of Georgia or in South Carolina, I saw someone say go Gamecocks, I would lose my medical license if I used diabetes medications in 1% of the patients that presented. If I just told them to go home and eat less and exercise more, and that sugar issue will fix itself. I know your blood sugar is really high. I know you just got admitted to the hospital, but just go home, eat less, exercise more, you'll be fine. That's exactly what we're taught in medicine about the disease of obesity. And it's problematic. And so it leads people to coming in to see the doctor. The doctor, they come in, they do their visit. The doctor's like, oh, it looks like you've gained some weight. What have you been eating? The patient's like, I get up, I have my overnight oats, and then in the midday, I have my salad and I have my this. And the doctor's like, are you sure? But what do you really have? Right. So I've been discounted everything you just told me because my presumption is that if you're doing that, you shouldn't look the way you do. Right. Or I asked you, what do you actually, oh, doc, let me show you. I've been getting 17,000 steps a day. That's, you're like, but what, did you just really just kind of run around in place and not really do anything? There's assumptions that we don't do with anything else. The problem is that lifestyle in and of itself doesn't typically shift set point. It doesn't shift how the brain sees weight. And so my goal is to work with the patient to figure out what works for their brain. We didn't spend time on that today. What medications, what combinations thereof, what surgeries, what combination of surgery plus medicine plus a device works for them, and then use it long-term so that I can sustain them with their weight loss. And so I come from public health. So I finished my MPH 21 years ago, just to date myself a little bit. And so, yes, I thought about, well, we got to prevent obesity. But we have to recognize that 42.4% of US adults have the disease based upon 2018 data. So it's more like 50%. So we're just going to forget the half of the population that already has it.
Totally.
Right? That's problematic. And then if we look in racial and ethnic minority populations, as a Black woman, obviously that's a group that I focus most of my time and attention. We're talking about 60% who have obesity, another 20% that have overweight. So we're talking about 80% of Black women with overweight and obesity. And so forget all of them. Let's just focus on the 20% that's normal. Problematic, so that's where public health, I think, fails us.
So why is it that, you said, I can't believe that you said 90-some% of your patients who,
you asked them, that's why there are 1,800 patients waiting to see me right now, but yes.
Wild. But so why, clearly you're good, but so why isn't that, why aren't your
my colleagues
methodologies more widespread? Why this is Right.
Yeah. So, well, I published a paper about that too, because Lily is a physician scientist. You got to publish about everything you talk about, right? So actually I did an analysis to see what are medical students being taught, not only here in the US, but around the world. So it's not that I don't care about the US by itself, but I wanted to see like, what are we being taught? What is everyone else being taught? Medical students, resident physicians, and fellow physicians. If we're not being taught it, you can imagine that we're not treating it, right? So no country, based upon the paper I published in the International Journal of Obesity, does a good job of teaching about obesity.
Mhm.
It's the most prevalent chronic disease in the world,
Right.
hence seeing all those studies,
Right.
but nobody seems to teach about it. Okay, I can tell you, even here at Harvard Medical School, when I first started at Harvard, we had a full, at least 3 days dedicated to the beginning of the second year where we specifically focused on obesity. That was taken away as they redesigned the curriculum. So here we have like literally some of the people that discovered leptin, et cetera, and we've taken away the education. So now, people get smatterings. Those people that rotate with me directly get to see how I work directly. But those are probably a little bit biased group, right? The people that say, hey, I want to work with Dr. Stanford, the obesity medicine physician. They probably have an inkling towards wanting to do that. What about the people that, I don't want to do that? And they're still going to encounter patients with obesity in any practice they go into, whether it's pediatrics or surgery or radiology. There's going to be a large percentage of the population they encounter. So if we're not being taught, then we're not learning to treat. So what I did was I came here to do 3 years of fellowship in obesity medicine to learn how to treat the patients that I saw struggling in my training in Georgia and New York and South Carolina, et cetera. Now, obviously in Massachusetts, how can I give them what I would want if I were in their situation? And so that was why I spent that amount of time. Right now, there are about 50 of us that are fellowship trained to treat obesity in the United States. Yet there are about 115 million individuals that have obesity. Some doesn't measure up. Now, there are a little over 4,000 that are now board certified, because we have like what's called a continuing medical education pathway where people can come and take courses and listen to people like me talk. Right. And then they can study for the test. Okay, so now we have 4,000, but I just said in just the adult world, we're talking, 115 million or so. And pediatrics, which I also treat, we're talking over 20 million. So we just don't have enough people that have any knowledge about this to know what to do. And so the reason we have 1,800 patients waiting to be seen is because they're trying to all come into us, the people that do this, well, when my goal is for you not to have to come to me unless you have a really significant case, like something that's really challenging, and you need the specialist, right, to get in. I want the primary care docs and the PAs and the NPs to know how to start this. And then they're like, Dr. Sanford, here's a challenging case. And that's the person I should be seeing. But if no one knows how to do any of it, I end up treating things that I could do literally in my sleep, and the more complex cases, which, require a little bit deeper thought and consideration.
Now, what role does food access and food insecurity? And I promise there's so many good questions and we're about to transition to them. But what can you talk about the role of poverty and food insecurity and how you reconcile that? That we're talking much larger societal and policy level issues. And so how do you reconcile that with individuals who you're working with?
Well, so absolutely. So I have to think about all those things. That's why my initial visit with every patient, which is part of why I probably take it forever to get to, is an hour-long visit. I can't just assume that everyone is the same. I can't assume that what Lily needs is what Fatima needs, what Sam and Jess, and just looking at the names, and Winona needs. Everybody needs different things, but I have to hear all of the stuff so I know how to best approach that patient. So I can't personally, well, I do. I mean, I talk to the White House and CMS and all those people all the time, but I can't individually change their what place they live, what their social stance is, but I can work within the confines of what I have to work with. Does that make sense?
Yeah.
So I'm taking those things into consideration. I'm not going to have someone who is both housing and food insecure go buy a Peloton, right? That would be unreasonable, right? Like to suggest that. But some providers might be, oh, just go buy a Peloton.
Right.
Peloton is about $2,500. Then you have to pay for the member. I mean, there's a lot of stuff that goes with that. I have to think about, okay, wait a minute. What do you have access to? Okay, well, let's try these modalities for you based upon what you say. And so I'm very sensitive to those issues and my patients. And then I have to just, come from where they are. I think about all of their social determinants of health and let that play a role in how I think about the treatment that they receive.
Definitely. So here's a piggyback question off of
Okay.
this. There's so many good ones. So we'll try to get to a bunch of them here.
Okay.
So question, hi to Liz Carlisle. Thanks for being here. I know Liz is out on the West Coast.
Oh,
So,
hi, Liz.
and I know you just mentioned that you do talk to the White House. And so she's asking about, do you think healthcare professionals have a role to play in public policy conversations and about food environments? And we're talking neighborhoods, schools, workplaces, and how can that be done effectively and respectfully?
Well, I mean, I think that, well, it's not just the food. So hi from the West Coast. I think the food, so I wrote a paper, of course, published it on why food policy and obesity policy are not the same. I think food policy is part of the conversation, but when you look at all of those things that contribute to obesity, if I hyper focus on food, which is what we've done and failed at, then we miss everything else. I think think of it as like a pie, right? And we've been addressing, like 1/10 of the pie, if you want to give it that. So 1/10 of the pie, but what happens to the rest of the 90%? And so I think that as health professionals, as physicians, someone like me, and that's what the AMA does, right? When AMA comes up with like a statement, right? This is saying, this is what doctors think. Not all doctors may not think it, but if it passes the House of the American Medical Association, it's presumed that most physicians believe it to be the case. For me, I'm serving as the key content expert on obesity for Congress, for both the House and Senate, for CMS and the White House. And so I do a lot of talks with them. I can't keep up often with the volume, but my goal is to educate them, because right now in the United States, for example, if you want to work directly with a dietitian, like maybe on addressing your diet, so we're going to talk about food environments, right now that visit is only covered if you have a diagnosis of diabetes. So you have to get diabetes to meet with the dietitian. Obesity, nope. You have to have obesity. Now you develop diabetes. Okay, now you get a dietitian. To me, that seems a little bit behind the 8 ball. Wouldn't we want to meet before we get the diabetes? I don't know. That's just kind of how I think. It's a complete exclusion under Medicare Part D right now for anti-obesity medications to be covered. They are outlawed completely, 0% will they cover. So there's a bill that we've been trying to get across the House and Senate floor since 2013. We are persistent. It's called the Treat and Reduce Obesity Act, which seeks to cover visits with dietitians. It's not rocket science. We think dietitians kind of know some things about food. It's kind of why they go to school. And then covering medications for the treatment of obesity. If CMS covers them, you can imagine that then has a downhill effect to Medicaid and to private insurers. And so this is work that I do all day, every day, but I think more of us should be involved and engaged, because we're best able to educate Congress and CMS, et cetera, about these issues.
Thank you. Here's a question from Claire Gleason. What is your opinion on the concept we learned about last week, health at every size? And do people need to lose weight to be healthy? So what is your take on it, Dr. Sanford?
So I'm very direct in that. I mean, I'm on the record whenever I say this. I'm not enthusiastic about the health at every size movement, although I will give some caveats and examples of why I say that. I do believe that adipose and or fat actually contributes to poor health outcomes. What we do know is that obesity itself causes over 200 obesity-related diseases, including 15 cancers, heart disease, musculoskeletal disease, endocrine diseases, et cetera. I can't go over all 200. And so weight is extremely important. Obesity is extremely important in addressing those diseases. I have the only profession in medicine where I have the ability and to delete diagnoses from people's charts. When I treat patients for their obesity, I sometimes run into the conundrum of not knowing how to bill them, because I've gotten rid of not only their obesity, but the chronic diseases that came with it. Thankfully, I can bill for history of a disease that they no longer have. So I can bill for history of obesity, history of sleep apnea, history of diabetes, history of fatty liver disease, et cetera, et cetera. When we don't treat obesity, we aren't affecting not only the disease itself, which leads to poor health outcomes, is the number one risk factor for both sickness and death related to COVID-19. I want to make that clear, which is why my TEDx talk on the collision of 3 pandemics, which was obesity, COVID-19, and racism, was so important for me to give. But we can't unrecognize the fact that obesity is characterized by chronic inflammation in the body. That chronic inflammation, for example, in the context of COVID-19, does not interact very well together, which is why we see such unfortunate sickness and death amongst individuals with obesity, with COVID. So now, sticking to BMI guidelines or a specific weight, I don't agree with. So I'm going to give you the story of a patient of mine. that I think will give you ideas of why I don't give a specific weight and why I try to get patients to the happiest, healthiest weight for them. When I first moved to Boston, I lived on the North Shore. I had to take something called commuter rail into Boston, and every single day I would take the commuter rail at 7:13 a.m. and I would see this train conductor, gentleman that had very severe obesity, and he'd be moving up and down, taking tickets, asking, doing all this stuff. And secretly, I wanted him to be my patient, but it would be a bit presumptuous of him to hand him my card and say, hey, I'm an obesity medicine physician, come to see me. So I didn't, because that would be a bit, going against the grain of what I say. Fast forward about 3 years, I walk into my office and my dream patient is sitting there, the conductor that had been on this train. And I walk in, he's there, 45-year-old gentleman, white male with his mom. Notice I said with his mom. How many 45-year-old men take their mom to their visit? But I will get to that in just a second. I walk in, I'm like, oh my God, you're the train conductor. I see you in the morning and you're always moving stuff and you're moving up and you're moving down and you're pulling this and this. And his mom starts to cry. She says to me, you are the first doctor in the 45 years that has been on this earth that believes that he does anything other than just sit down. And you're enthusiastic to see him. And she cried for the first 10 minutes of his visit. When he came into that first appointment, he weighed 550 pounds. We have been able, with different treatment modalities, to get him to 300 pounds, and he's maintained that for the last 5 years. Now, with that, getting from 550 to 300, he's lost 250 pounds. If you were to use your biases and look at him, you'd be like, oh my gosh, he's unhealthy. He needs to get his life together. If you didn't know, recognizing that he's resolved all of his chronic diseases that he came in with on day one. So I don't agree with health at every size, but for his size, he was able to get from 550 to 300. That's where his body likes to be and where his body moves away from those chronic diseases that plagued him. He's able to move in a way that he's been promoted even at work. I mean, it's really interesting to see, not only did his health change, his health-related quality of life and his quality of life changed. And so I think that when we think about the health at every size movement, it neglects looking beyond just the size of the person, looking beneath the hood, if we want to think about it as like a car, doing that deep dive to see what is going on. And so with every single patient that I see, I don't just look at their weight. I look at their weight, I look at their waist circumference, I'm going to look at their lipid panel. Do they have fatty liver? Do they have hyperinsulinemia? All of these things, because then I'm able to tackle the whole them and the treatment of their obesity.
Great, thank you. I'm seeing lots of questions on several different themes. I think you already probably substantially addressed this, but I just want to say that there's a lot of curiosity, especially on piggybacking on last week's session about language, and people are definitely interested in. Last week, our speakers referred to the O words as overweight and obesity, and we're interested in reclaiming this word fat. It makes, honestly, this is why we have you all, because
right.
It's a complex world.
Yeah,
so I want to highlight that and just recognize those differences. I don't know if you want to say anything more on terminology.
I think just the key thing is that when we think about fat is an organ. Okay, so fat is not a descriptor of how someone looks. I mean, although I used it myself at the age of 5, right? But I used it in a negative way. And so when I think about, and I talk to people that are fat activists and things of that sort, I ask them how they would have felt if they were 3, 4, 5, 6, and someone came up to them and called them fat, or punched them and called them fat, or whatever it was, then called them fat. And I don't think that any of these people would say that they would have felt comfortable with that. As they've matured, they feel, okay, well, let me just reclaim that. We could say, as a Black person, do I reclaim the word nigger? I mean, that's kind of what it feels like the equivalent to me is. And I don't like to be called that. So don't.
Or maybe reclaiming the word queer, perhaps.
Yeah, but queer is different, right? So queer is not like, it's not the same. I think that queer is because when we think about the LGBTQIA community, there's so much terminology that can be utilized. I don't see it in the same way, Lily, as I do fat. I don't think that people at 3 know what queer is. I mean, maybe they do. I don't know. Maybe you guys knew that. I didn't know that when I was 3. You see what I'm saying? There's a difference, right? Like, that's why I don't see those in the same way. So I just want to be mindful that fat is an organ. We do study fat. I study, my personal work is not looking at fat or adipose tissue, but there are there are whole labs and whole communities of researchers here that are studying the organ that is fat. White adipose tissue, so white fat tissue, knowing that it burns less than brown adipose tissue. So brown adipose tissue inducing hyothermogenesis, higher burn. Fat is an organ, fat is not a person. So that's how I think about it.
I hear you. Great.
So, I mean, if there are no other questions, I don't know, Lily, if you have any additional. If not, I want to thank everyone for being here. I think it's really important for you to hear also the science side. There are lots of my live lectures kind of floating all over. If you want to learn a little bit more about those treatment modalities, which I spent less time on because I wanted to focus on how the medical community contributes to weight bias and how we are often to blame for that. But a lot of that comes from a poor understanding of the science of the disease, which we are hoping to help address. I really want to think about those things. You know, I've heard people talk about the O word being obesity, and the fact that, you know, this is what is recognized as a disease. There are colleagues of mine, for example, the University of Alabama in Birmingham, that want to change it to ABCD. That would stand for adiposity-based chronic disease, which is has a nice ring to it. But, you know, how many people understand adiposity? There's a lot of different things. And so I can understand why the word obesity is viewed negatively, mostly because we've used it negatively in a derogatory way. As an obesity medicine physician and scientist, I don't see my work as derogatory in any way. It actually provides tremendous joy. And I tell my patients that I sometimes think I'm more excited than they are, but I think that sometimes I'm just so excited because I've seen how hard their journey has been, whether or not they've utilized different treatment modalities, recognizing that surgery is not the easy way out or medicines is not the easy way out. I just talk about using the right tool for the size of the problem. And so when we think about these snowstorms, these big snowstorms that come into our areas in Michigan or Massachusetts, I always start off with my patients and ask them, what will be the appropriate tool to handle the 23.6 inches of snow that we got on Saturday, or I think the 12 to 16 that you guys have recently gotten or are getting soon. And most people will say that we should use a plow to probably move the snow away. But we often take a teaspoon size approach, which means just using lifestyle modification, which doesn't get to the size of the problem in those particularly that have moderate to severe obesity and their brain defending a super high set point for weight. So I just want to bring all of those things up. Lily, if you don't have any other things, I'll turn it over to the team. And thank you guys so much for your time and attention on Tuesday, February the 1st, 2022 in this evening time, except for those out on the West Coast.
Thank you so much, Dr. Stanford. And Margot and Winona, I'll pass it back to, or how about Winona, you can introduce our speakers for next week. How about that?
Okay, oh, love to. So next week we will have Dr. Marcus Coleman, I'm tongue-tied, and Angela Chalk, and they'll be talking, they're from New Orleans, and they'll be talking about beginning farmers and feeding community. So looking forward to that discussion.